The meeting is live on YouTube. I'll share the link with you, Poonam.
Okay.
It started already, okay?
Oh, Manisha.
I just wanted to know, is there a lot of background noise in my audio? Is it okay?
It's fine, sir. There's no background noise.
We will start the session in 5 minutes. At 5:05, we will start the session. Good evening, everyone. I am Manisha Hinduja, the Secretary of SOCVPR, and we'll start today's session that's Empowering Physiotherapists, an initiative to improve our collaboration between the medical field and the physiotherapy field to overcome TB. I request Poonam Parulekar, the Joint Secretary of SOCVPR, to please start the meeting.
Good evening, everyone. Welcome to today's special event commemorating the World TB Day. We gather here to reflect on the progress made, the challenges ahead, and the collective efforts needed to end tuberculosis epidemic. Together, we stand united in our commitment to eradicate TB and ensure a healthier future for all. I would now like to call on our President, Dr. Maria Giandani, to please welcome everyone and introduce our today's esteemed speaker, Dr. Sarthak. Maria ma'am, over to you.
Thank you so much, Poonam. And a warm welcome, Dr. Sarthak, over here in the Society of CVPR. And welcome to all our colleagues who have joined us today. The Society of CVPR, just to give a brief introduction, has been a registered society with Charity Commissioner. It's pan-India. It was registered in December 21, and we have a mission of reducing the health burden and improving quality of life of patients with cardiac and respiratory diseases. We have had a number of workshops and CME for the same. And in December, we had the first national conference of the Society of CVPR. Last month, we have just launched on the Pulmonary Rehab Week a patient support program called as Laksh. And we look forward to collaborations with all the healthcare professionals in order to take this mission forward. And for the same reason, today, sir, we have you here and on the World TB Day, that is tomorrow, with the mission, yes, we can do it, we can end TB. So just a brief introduction of Dr. Rastogi. He's a well-known pulmonologist in Mumbai. He's been practicing in the hospitals like Holy Family, Raheja. He's been attached to Hinduja Hospital as well. He's got a huge experience in treating tuberculosis patients, which are drug-resistant TB also. His specialization also goes and extends to bronchoscopies and sleep labs. And he's got a huge experience as well in the obstructive and the ILD dysfunctions. Sir has got multiple publications in international forums. He's got his poster presentations, and he's a very generous and humble human being. So with this brief introduction, sir, I would like you to take us through in how we can help and empower patients with tuberculosis and how we can be support in TB. We do get a lot of patients which are pulmonary TB sequelae, that is post-TB. We get chronic bronchitis, bronchiectasis, and they are for destroyed lung and they're on for a long rehab. And we would seek guidance from the Maharashtra State TB Association and all the chest physicians, and look forward to you enlightening us the path forward. So over to you, sir.
Thanks a lot, ma'am, for the kind introduction. Just one correction I would like to make. I had trained at Hinduja. I'm not attached to Hinduja anymore. Anyways, going forward, it's a pleasure meeting, ma'am. Finally, I've worked with a lot of your students in the past, including one of my thesis or dissertation during my post-graduation was on pulmonary rehabilitation and interstitial lung disease with Dr. Mrinmay. I hope she has joined in. But anyways, I've worked with several of the delegates who are present here, and it's a humbling experience. Especially, this is the first meeting where I can see majority of the participants are females. In fact, all of the persons who have joined names, I can see I'm the only male. So quite humbling. Thanks for having me here. So I'll just start sharing the screen. Sure. Can you see my screen?
Yes.
Yes.
So for the topic for today, we'll just go through a little bit of brief epidemiology, clinical manifestations and risk factors, especially when it comes to physiotherapy and especially pulmonary physiotherapy. The problem is most of our patients who are requiring physiotherapy, either their lung defense systems are compromised or they are on some form of immunosuppression therapy. For example, a person of asthma or COPD may be on will be on some form of steroid therapy, especially oral corticosteroids. They are prone to getting tuberculosis. So one of the commonest thing is when a physiotherapist or a person providing any form of therapy is coming into patients at risk for tuberculosis, they should be able to identify and refer the patient to a physician. That will be the biggest help or the biggest thing to further our passive case detection load. India is trying for active case findings as well, but that should be the primary thing. And then we'll go to general infection control measures. Briefly, we'll talk about infection control during physiotherapy and role of PT in TB from a pulmonologist perspective. And I would here rather have people's experience or participants' experience about how they have found the physiotherapy in TB or how they have involved themselves in taking care of TB patients. And then we can have a brief interactive session. Hopefully, I'll wrap it quite rapidly. I have around about 45 slides. I have not included the latent TB screening or much of extrapulmonary tuberculosis into the discussion because I find the latent TB guidelines which are being pushed right now a little controversial, but we'll save that topic for another day. And extrapulmonary physiotherapy, extrapulmonary tuberculosis will unnecessarily complicate and delay the topic or prolong the topic of discussion. So going ahead, starting with a grim reminder. Just a minute. Yeah. A grim reminder, by the end of this talk, around 180 people would have succumbed to TB or TB-related complications. That is almost 3 patients per minute are dying. And as Jim Murphy, an author, a children's book author who has written a wonderful book, I would like each one of you whosoever is interested to go and read his book. After centuries of ineffective treatment, the microorganisms that cause TB was identified and the cure was thought to be within the reach. But drug-resistant varieties continue to plague and mimic the human race. It's a very illustrative book, and I would recommend everyone to pick up a copy and read about it. So, yeah. So almost 2 billion people are infected with Mycobacterium tuberculosis worldwide, and each and every one of these 2 billion, there is a 10% risk of developing active TB in their lifetime. And anyone who has latent TB or who has been infected with MTB, who has been infected with the MTB is at risk of developing active tuberculosis with a risk of 10% annually. So you can understand why it is important to identify a patient of TB or with HIV co-infection or any HIV patient to undergo regular screening. Every year, about 10 million people develop TB disease and 1.6 million people die out of it. This is a 2021 estimate. We are waiting on further changes yet. Probably this year we'll get more of it. TB is the leading cause of death due to infectious disease. And briefly in 2020 and 21, COVID-19 had surpassed it. But TB did not have any difficulty in regaining the top spot. Even before the vaccines were widely available, TB had regained the top spot. Earlier, there was a resurgence of TB during HIV pandemic in Western countries, which had managed to control and eliminate TB to a large extent. And similar thing we saw in COVID-19 pandemic also, because of disruptions of the TB-related services. And for the first time since 2003, the cases of the incidence of TB globally had risen. Around 2003, the TB global incidence peaked and it's decreasing slowly. So that's some good news. As far as India is concerned, we come into the high incidence, high burden country where at least more than 300 people are affected per 100,000 population annually. India's rate is somewhere around 450 to 500 cases per 100,000. And for us to achieve the elimination mark, we have to come down to 1 case per 100,000 population. China, our closest neighbor, and one of the other countries with highest load is a moderate incidence country. Poverty, HIV, and drug resistance are major contributing factors to resurgence of the epidemic. About 95% of TB cases occur in resource-limited countries like ours. 1 in 12 new TB cases occur in individuals who are infected with HIV. And thankfully, India is a country where HIV incidence is decreasing and is on the decline. 74% of these HIV co-infected persons resided in Africa. So as you can see, India is somewhere here, and we are between 300 to 499 mark. So there are countries which are higher in incidence, but as far as India is concerned, we are the leader, and if it was something to boast upon, we would have been a superpower in terms of tuberculosis. An estimated 465,000 cases of multi-drug resistant TB or rifampicin resistant TB occurred in 2019. And again, India had the lion's share in MDR and drug resistant TB as well. The socioeconomic factors are one of the main things that we need to achieve, we need to address as far as TB control is concerned. And why it is so important? Because before an effective chemotherapy for tuberculosis or combination chemotherapy was designed, Europe had almost eliminated tuberculosis, and it was largely due to socioeconomic development, improved living conditions, better nutrition and assistance to their population. And in some extent, they had isolation at sanatoriums, which is no longer considered to be something which we should be considering in the future. So the things we have to act upon is socioeconomic development, improving the living conditions, better nutrition. Briefly, we'll talk about NTB strategy, which is the deadline is 2035. The time started between 2016, and the focus is on reducing deaths, reducing disease incidence, reducing catastrophic costs due to tuberculosis. The new goals include a 90% reduction in TB death and 80% reduction in TB incidence by 2030. Now, India has become more ambitious, and we trying to achieve both of these goals by 2025. But it doesn't look like that we are going to achieve that by 2030 also as well right now. But let's hope the next year brings better results. Accomplishing these goals will require accelerating the decline in TB incidence. Currently, every year, the incidence is declining by 1.5 to 2%. And we have to bring this incidence decline to 15% annually. And if we are able to achieve that by 2050, we will reach the elimination mark, that is less than 1 case per million by 2050. Eradication mark. Achievement of this goal requires improvement in diagnosis, completion of disease treatment, and latent infection diagnosis and treatment. So this is again a busy slide, but NTB, WHO's the NTB strategy. The main vision is a TB-free world, zero deaths, disease, and suffering due to TB. So for what is the milestone for 2025? This is the global, this is not the Indian thing. 75% reduction in TB deaths compared with 2015. 50% reduction in TB incidence rate, less than 55 TB cases per 100,000 population, and no affected families facing catastrophic costs due to TB. So again, I would like to highlight this point: no affected family face catastrophic costs related to TB. So the good thing that we have started is a public-private partnership mix, in where any patient getting treated with a private physician or at a private hospital can avail free TB treatment and free TB diagnostics through the government programs as well, and they can continue their treatment with a private setup physician or private care facility. So that's the big thing. So in any case, if you have a patient who's not willing, who's not affording, and who's not willing to go to a government hospital because of fears, there are a lot of fears in approaching a government hospital, so they can avail of this services. And each and every area of Mumbai is right now covered in this. WHO estimates that roughly 30% of active TB cases are never diagnosed. Therefore, active case finding is needed. Programs need to screen for TB disease among patients not seeking healthcare for symptoms. So we have to go to community and find out the active cases. And approaches for radiographic screening, sputum screening, and symptom surveys. One of the ways that NACO does case findings is whenever a patient comes for ART, they always without fail for each visit, they will do the 4S screening. And this is the simplest thing that even each and every healthcare physician can start and can consider for their patient population. Any patient who is at risk of tuberculosis, we should ask these 4 symptoms. That is cough of any duration, fever, weight loss, and night sweats among adults. So any of this is present, we should consider that they can be having tuberculosis. While this 4S is very specific for HIV program, we can slightly alter to other non-HIV population is cough of more than 2 weeks, fever of more than 2 weeks, weight loss, and night sweats among adults. Now, in pediatric population, we'll slightly tweak it to current cough, fever, poor weight gain, and history of contact with a TB case. So pediatrics is a special population where community infection doesn't matter much, but they are usually is diagnosed with tuberculosis, we have to look for a close contact with tuberculosis. That's the usual case. Active case finding in India. So right now we are shifting again. So in there was a time when we used to do active case finding, and in RNTCP we shifted our focus from active case finding to passive case detection. But again, in lines with the sustained developmental goals and NTB strategy, we are shifting our focus to active case finding again. But the utility of active case finding in India is somewhat limited. Optimal approach to finding individuals with undiagnosed TB in high incidence regions is uncertain. Most cases occur in absence of recognized risk factors. That is a normal person who's not on any immunosuppression, who is not in close contact with a TB patient, can develop the TB disease. In studies done globally, it has been found that in high burden countries, the passive case detection does better than active case findings. But in order to achieve the NTB strategy, we are shifting a focus again to active case findings. LTB screening and treatment. LTBI is latent TB infections. Usually it is aimed at upper and middle income countries. And WHO has suggested that every nation should develop its own strategy. India has come up with its LTBI screening guidelines 2 years back, and treatment as well. So we have to identify and treat individuals with LTBI at increased risk of progression from latent infection to active disease. So earlier in the talk, I discussed a normal person with latent TB infection has a 10% lifetime risk of developing TB infection, whereas a patient with HIV has a 10% annual risk of developing TB. So obviously a patient with HIV or immunosuppression or diseases like diabetes or malnutrition are at an increased risk. So WHO suggested efforts on case contacts and individuals with HIV infections, patient initiating anti-tumor necrosis factor treatment that is usually given for patients with rheumatoid arthritis or inflammatory bowel disease, patients receiving dialysis, patients preparing for organ or hematologic transplantation, and patients with silicosis should go under latent TB treatment, and case contact should be done for these, regardless of which population they are in. So while India is concerned, when we talk about that 30% of active diseases are never diagnosed, half of those are from Asia, including Indonesia, India, and China. And many of these patients are co-infected with TB and HIV and not recognized to be co-infected. That is, a patient diagnosed with tuberculosis is not aware that he is HIV positive as well, and an HIV positive on treatment is not aware or has not been diagnosed with active TB disease. The worldwide percentage of patients with TB disease who underwent subsequent HIV testing improved only marginally between 2002 to 2015. But since 2017, India has taken the initiative, and any patient diagnosed with TB will undergo an HIV test. An HIV test should be offered. That is the guideline and sort of has become the dictum and a standard of care right now in India. WHO estimates that only 1/3 of patients of MDR TB were identified, and only 60% were successfully treated. Out of these patients who get diagnosed, more than 1/3 succumb to their disease or remain a chronic TB patient for their remainder of their life. So what are the risk factors and how do you identify your patient in your practice can be at risk for tuberculosis? So there are impaired immunity, that is the host factors, and increased exposure to infectious persons. That is generally all our patients. Host factors includes immunosuppression. Immunosuppression can be because of HIV, substance abuse, and alcoholism. Tobacco is associated with increased incidence of tuberculosis. So all our patients who are currently smokers should at some point of time go undergo TB symptom screening at least. And malnutrition. I have not included the drugs here, but as we all know, the commonest offender is corticosteroids, and most of our patients are on corticosteroids. Systemic diseases like diabetes, malignancy, and chemotherapy, ongoing chemotherapy treatment increases the risk for tuberculosis. Patients on dialysis and chronic kidney diseases, gastric disorders like celiac disease. Celiac disease makes a person immunodeficient because of malabsorption, COPD, cirrhosis, and mental health disorders. Exposure-related factors. So, socioeconomic factors. We are all aware poverty is the main driving factor or the main driving force for tuberculosis. Minority groups. Now, minority groups are usually not in the main force and are usually neglected when it comes to health and other occupational opportunities. And these are the special population that we should concentrate and work hard to identify tuberculosis in these communities. Incarceration, prison patients from prisons are at a special risk at a higher risk for getting tuberculosis. War and natural disaster related displacements, living in refugee camps is one of the main reasons for developing tuberculosis amongst other infectious diseases. A household contact having tuberculosis. So we should take this history with all our patients, whether there is any patient who is having active TB at home, then we should screen those patients for tuberculosis as well. Living in a high burden country like India, obviously. So whenever a patient asks why he or she developed tuberculosis, some of the doctors with a tired face, they give a reply, okay, boss, you live in India, you live in Mumbai, you're prone to get tuberculosis. So there's nothing new in this. So we should show a little bit of empathy here. But anyways, institutional living, psychiatric facilities, old age homes. Now, I understand a lot of our physiotherapy colleagues do visit old age homes and serve a geriatric population. Geriatric population, especially in the lower economic homes, they are sort of a rampant place to develop tuberculosis. So we should keep in mind that if a patient is coming from an old age home, we should ask each and every time and assess frequently for tuberculosis. So once TB bacilli enters the body, what happens? There is a natural clearance. Okay, you inhaled it and body is successfully cleared it out. Nothing happens. End of story. Latent TB infection, the bacilli enters, body's defenses are able to understand it, develop a response, and arrest that bacilli from developing further. Sometimes, because of some risk factors, a patient can have reactivation of latent TB. That leads to post-primary disease. And rarely, or not rarely, uncommonly, a patient is not able to mount any defenses, and TB, as soon as it is inhaled, starts developing into an active infection. So, failure of the host to mount an effective cell-mediated immunity leads to progressive tissue destruction, manifesting as symptomatic primary TB disease. So, usually childhood or adults with immunosuppressions are more prone to developing primary TB disease. So, for example, a child who's malnourished otherwise may develop a classic primary TB disease, or an American residing in India and has come for other purposes, develops a lower zone TB or a miliary tuberculosis. That happens most commonly because of primary TB. So primary TB, most prominent symptom will be a high-grade fever or a pleuritic pain. Cough, weight loss, and anorexia occurs in patients with lesser frequency, and weight loss and anorexia happens more if the patient goes undiagnosed with the disease. Post-primary TB, that is the reactivation tuberculosis. There is cough, weight loss, and anorexia as the most prominent symptoms. Here we have to pay attention that fever only occur in 1/2 of the patients. Sorry for the typo here. Only 1/2 of the patient. So a patient just with cough can be of tuberculosis without fever as well. So medical risk factors for progression of TB includes HIV, diabetes, immunosuppressions. We have discussed this. Chronic renal failure, leukemia or lymphoma, hematologic malignancies, that is, head and neck cancers, anyone with weight loss of more than 10% below ideal body weight. A lot of our patients go on this something called as GM diet, General Motor Diet, which includes starvations and eating specific group of food. And I have personally encountered several patients who underwent GM diet 10 years back when it was quite a fad, who developed primary tuberculosis or symptoms or features suggestive of primary tuberculosis. So anyone who is coming to physiotherapy for weight loss or who's undergoing weight loss, we should screen them and we should identify them and warn them that they are at risk for tuberculosis and we have to pay special attention. We frequently see patients being referred to physiotherapy post-gastrectomy and jejunal-ileal bypass. Now, these patients start developing rapid weight loss after this surgery, and they undergo malnutrition as well as because of poor absorption of nutrition from the gut, because they have created a bypass. So these patients are also at increased risk of developing tuberculosis. So briefly touching about infection control and how we can save ourselves. So elevated risk for TB transmission via droplet nuclei includes presence of active untreated pulmonary or laryngeal TB, presence of cavitary disease, sputum with positive gene expert, that is nucleic acid amplification test, presence of sputum with smear for acid-fast bacilli, and presence of sputum with positive MTB culture. And any patient whose sputum came back quite rapidly is also highly infectious. While negative sputum AFB smears suggest a lower organism burden, they are not to be treated as non-infected patients. So a lot of our healthcare workers think if patient is just having an X-ray opacity, but their sputum results were negative, especially a sputum AFB smear, they forego their infection control measures, which is a big mistake. So we have to protect ourselves and we have to take care that other patients are also protected. Procedures that lead to an increase in dispersal of droplet nuclei infection. Mind you, tuberculosis is a droplet nuclei infection, and COVID and influenza and other viral disease are usually droplet infections. The main difference is when a patient sneezes or coughs, there are droplets of mucus which are coming out, so respiratory secretions which are coming out. In case of a droplet, they go and after a short distance of traveling, they settle down on the surface. But TB is, after that, the secretion, there are a lot of droplet nuclei which remain suspended in the air and which remain airborne from several hours to a day as well. So, what are the procedures? Endotracheal intubation, bronchoscopy. Now, something which is very important is sputum induction and chest physical therapy. These, and most of you are giving chest physiotherapy sometimes to undiagnosed and unidentified TB patients. Administration of aerosolized drugs, again, a common practice at most of the pulmonary rehab centers is during or before or after a session, they are given nebulizations. Irrigation of a tuberculous abscess, that we don't need to worry about, and autopsy is something, again, which is just for academic discussion here. Patients with isolated extrapulmonary tuberculosis are not contagious. However, you have to ascertain that a careful evaluation has been done of a concurrent pulmonary or laryngeal tuberculosis. Concurrent pulmonary TB is common in patients with pleural effusions as well. So a patient is coming to you with just a pleural effusion, doctor said, okay, we have just tapped and they have not investigated sputum. Insist upon a sputum test to be done and then only take away the respiratory precautions or infection control precautions. immunocompromised patients with extrapulmonary TB should be presumed to have pulmonary TB until and unless proven otherwise. Important measures for a successful program includes designating responsibility for TB infection control and having a written TB infection control plan. Components include use of airborne infection isolation. So a lot of this time there'll be AII written in the slides. Don't confuse that as all or A2 something. It's AII, it's airborne infection isolation. And respiratory protection. Healthcare workers should be educated. So educate all your patients or all your allied staff and all your juniors about how to identify a patient with tuberculosis with active symptoms, how TB is transmitted, and how it can be prevented. So coming to airborne infection isolation, all the negative patient ideally should be kept in negative pressure room. In India, that doesn't happen most of the times, especially in government setups. And airborne isolation room is a single occupancy patient care room with a ventilation system that generates negative pressure. Means the air can come from outside into the room, but cannot go from room to out. Okay. So for patients, we need for a chemotherapy patient or a bone marrow transplant patient, we need a positive pressure room. That is, the air from inside can go out, but not from outside to in, preventing an infection in the patient. Here we are talking about reverse, and negative pressure rooms are slightly more difficult to maintain, especially in a country like India, where maintenance has to be quite high. So whatever air can come from the door into the room, and it is taken out into the atmosphere where the droplet nuclei are diluted in the atmospheric air and neutralized by the sun. So what if you don't have airborne isolation rooms and you still have to deal with infective TB cases, or you have to deal with patients who are at risk or are suspected of TB cases? We have to ensure at least 6 air changes are happening. That is, the air, the entire volume of the air inside the room is changing 6 times per hour. The ideal for construction is 12. Now, calculating this and executing this again is very difficult. We have to have excellent biomedical personnel and motivated force. But what we should take care is wherever we are treating patients, there has to be a unidirectional airflow. So installing exhaust fans in such OPD areas where the air can be sucked in from the inside the air and taken outside should be at least present. If not that, at least we should not be dealing with these patients in areas with air conditioners or areas with centralized unit. So if in hospitals, it is not possible to provide mixing of air, we should install HEPA filters at the exhaust ducts to trap the infectious droplets. Cough hygiene should be taught to each and every patient, whether they are having TB or they are at suspect of TB or not. Patient should wear a surgical mask when leaving the room or during procedures like physiotherapy. So when should healthcare workers wear a mask? So whenever there is a suspected or active infectious TB cases in the presence of the room, you should always wear an N95 mask. While accompanying a patient with known or suspected active infectious TB, such as during transit, you have to wear a mask. And during any of these enlisted procedures, especially chest physical therapy, you have to wear an N95 mask. And only wearing an N95 mask is not important. A proper way of donning and doffing the mask should be taken care of, and we should follow it. And so why N95 mask? It filters any particles of more than 1 micrometer in diameter. That is, all the droplet nuclei will be trapped in. But the basic problem with N95 is, although theoretically it should prevent more than 95% of the flow, there is usually a misfit for most of the people. So just wearing an N95 is not enough. We have to get the mask fit test to be done annually. As you can see, I'm having a beard. Normal male doctors with bushier beard or anyone with facial or dental anomalies or ENT anomalies, the mask do not fit well, as well as people with longer axis oval face, different type of mask will be utilized. People with round faces, different type of mask is needed. So a mask fit test needs to be done. Unfortunately, again, most of the healthcare facilities are not doing it. If somebody is there who does not or who continues to fail a mask fit test, there's a special mask available called powdered air purifying respirators available. Slightly uncomfortable to breathe in, but that's the ideal alternative. I've seen a lot of physiotherapists wearing a surgical mask and doing physiotherapy. The biggest problem with surgical mask is that it prevents the respiratory secretions from being released into the environment from the person who's wearing. So if I'm wearing the mask, my respiratory secretions are being prevented from going into the atmosphere. That's why a surgeon operating wears a mask so that he doesn't contaminate the operative field with his respiratory secretions. But it does not do any benefit while inhaling the air in. Patients need not wear a mask when they are inside the airborne isolation room. Otherwise, they need to. Patients with known or suspected TB do not require an N95 mask. So a lot of times I've seen during physical therapy, patients with suspected TB are being given an N95 mask, which is really uncomfortable for a person with active lung disease to wear and to breathe through and to exercise at the same time. So, and plus, what we are doing is we are preventing him from inhaling infected air, but it does not do much to prevent the air from getting out. So it's when somebody is wearing N95, it's for personal protection, it's not for others' protection. So ideal scenario is the patient is wearing a surgical mask and the healthcare provider, the person who's doing the physical therapy is wearing an N95 mask with a proper air changes in the room. That should be the ideal scenario. So contact tracing should be done for any patients who is found to have tuberculosis. And if your patients are getting physiotherapy in group sessions and some person turns up TB positive, a TB positive patient, a smear positive, or somebody who's highly infected at the time of diagnosis, he was infected for last 3 months, unfortunately. And a person who's testing negative but is found to have disease or a smear negative at the time of diagnosis, then the contagious period is around 1 month. So we should go back 1 month and we should contact trace all the patients who are in that same group. Assessment of compliance has to be done strictly and should be instituted by the leader of the healthcare workers. And patients, we have found that patients are regularly not placed where they are supposed to be. Anyways, so this is just compliance measures. We have to strictly follow the compliance. So when it comes to your patient at risk for TB, whom do we identify and send them back to their primary healthcare provider for diagnosis of TB, a cough of more than 2 weeks, unexplained cough and fever in the context of HIV infection, community-acquired pneumonia, a patient who was diagnosed with pneumonia, has not improved after 5 days of treatment. Incidental findings on chest radiography suggest of TB. And I've seen this with most of our colleagues in pulmonary rehabilitation is that they do care to look at X-rays and CT scans before starting a session, and which I must commend that such high compliance is not seen with other branches. So pat yourself, pat your back, and please keep on doing it. And whenever you find somebody with abnormal X-ray, do not hesitate in discussing this out with your referring doctor. So I see measures which are pertinent to physiotherapy. So whenever a patient suspected of tuberculosis is having aerosol generating procedure, mainly a nebulization, step out of the room. Using safe nebulizers, usually an ultrasonic nebulizers, generate less aerosols. Using masks with shields, which are not available and not convenient, is another option. Create a separate room for nebulization and sputum induction with exhaust. And assess the patients prior to initiating, as we have discussed. Discuss with the physician if you find anything. Periodically assess all your patients at risk for tuberculosis. We can modify the 4S, which is the simplest way, making sure that at least that 12 air changes per hour. It's very difficult to do it without a civil engineer who has biomedical training, but at least getting a large enough window with exhaust fan should be the main thing. Asking the physician to switch nebulizers to inhalers with spacers, at least during the physiotherapy sessions. Wearing adequate respirators with any patient at risk with any of the symptoms previously discussed should be considered infective unless it's proven otherwise. Lastly, briefly touching upon physiotherapy in TB. Most thing where people forget is the biggest role of physiotherapy is preventing invasive procedures. A lot of my patients with sputum induction and chest therapy, percussion therapy, are able to give out a good sample. So there is a patient who is at a risk of tuberculosis. Please wear N95 in such patients. Management of critically ill patients on mechanical ventilators or any patients with cachexia or sarcopenia due to tuberculosis. Mobilization and active passive therapy in cases of extrapulmonary tuberculosis, especially CNS and spine diseases. Post-TB lung sequelae management is the biggest place where people are physiotherapy, pulmonary rehabilitation has shown to be the mainstay of therapy. Benefits of PR are reducing symptomatology, improving the degree of functional independence and quality of life, increasing the ability to perform daily activities. While I was searching, I found this article, Physiotherapy in the Treatment of Pulmonary Tuberculosis, from 1925. Although I could not read much into the review, but quite an insightful thing that the role of physiotherapy was initially seen and then forgotten, and then we are only realizing in the last 10 to 15 years. With advent of COVID and video consultation, one field which has done the most in terms of video consultation is physiotherapy, and I must commend all the pulmonary rehabilitation experts who are doing this via video. Most of our patients are oxygen bound or home bound and cannot step out, and are getting good quality physiotherapy sessions on Zoom. They might be a little inadequate, but this is one way we can involve physiotherapy in treatment of active pulmonary tuberculosis as well. A ray of hope. We had achieved Millennium Developmental Goals of reducing TB incidence by 1.5 to 2% by the year 2015. Government of India has taken the challenge head on and released several initiatives, including the self-achieving SDG goals ahead of time by 2025 instead of 2030. LTBI guidelines were released. 3 new drugs are available to treat drug-resistant tuberculosis. A wide array of testing is available, including whole genome sequencing for TB, and the cost is being brought down quite significantly. Patient-public partnership is available. Survivor and patient advocate groups are active more than ever, giving their side of perspectives what needs to be treated. So I started with a quote of Jim Harper. Now I'm ending with another author. Courage does not always roar. Sometimes courage is the quiet voice at the end of the day saying, I'll try again tomorrow. With this, I conclude. And time for some questions.
Thank you, sir. So we have a question from the audience. Are post-COVID-19 patients at risk of TB disease? And any recent literature or data on the same?
So post-COVID, as such, patients who had with any infective disease which is leaving a lot of sequelae in the lungs are at increased risk of tuberculosis. So if you're seeing a patient with post-COVID ARDS, he is as prone to developing a tuberculosis as a person with post-influenza ARDS. But frankly, we have not seen many patients with tuberculosis with extensive COVID. But since it was such a rampant infection with almost everyone getting some form of the COVID infection or the other, it's very difficult to comment whether just because of post-COVID sequelae or because of COVID, TB has increased or not. Yes, during the COVID pandemic, there were a lot of services which were disrupted. A lot of patients did not have proper food and medicines, access to medicine. That's why we saw a brief uptick in TB incidence, and which is normalizing now.
Thank you, sir. We have another question. When should one commence physiotherapy post-diagnosis of TB?
So any patient who is having residual symptoms after tuberculosis, let's say a patient of pulmonary tuberculosis who's left with significant obstructive airway disease, we should commence after completing the therapy. Or in fact, if the patient is symptomatic during the end of the treatment, also we can commence physiotherapy. So anytime after sputum conversion and 2 months of treatment for a drug-susceptible TB has elapsed, patient is usually safe for pulmonary rehabilitation in terms of infection control.
Thank you. We have one more question. After starting anti-TB medicine, after how many months it would be safe to enroll them in pulmonary rehabilitation?
Again, so it's basically an individualized approach. Most of the patients with drug-susceptible tuberculosis become negative by the end of 2 months. And 3rd month onwards, it's safe. But somebody who has diffuse disease, who actually will be the real candidate for pulmonary rehabilitation, it might take a little longer. So having a discussion with your physician needs to be the most paramount factor. Okay, and unfortunately, there are no guidelines when we can start. But anyone with significant symptoms and has become negative should be enrolled. But any patient with active TB infection having a lot of weight loss, muscle loss, also becomes a candidate for pulmonary rehabilitation. In that case, we have, if proper infection control measures can be instituted, then I think so physiotherapy should be started as soon as possible.
We have one more question from Maria ma'am. Should they be tested again for sputum AFB
So
after they are...
What time are we talking? So as per the guidelines, any patient who has completed tuberculosis treatment has to be under surveillance for next 2 years also has to be under follow-up. Sorry, has to be under follow-up with sputum test being done on them for the period of 2 years. Now, unfortunately, due to lack of resources or some other reason, a person with drug-susceptible tuberculosis only undergoes sputum AFB smear, which is inadequate, and a patient with drug-resistant tuberculosis goes on for 6 monthly sputum TB culture testing for a period of 2 years after finishing the treatment. So yes, most of the patients should be undergoing sputum AFB testing, smear, as well as culture testing frequently till at least 2 years.
So, one more question from the audience. After AFP negative report, should we wait for 1 month to start the person with physiotherapy?
So again, when we are talking about sputum AFB negative, if it's a smear, that doesn't indicate that patient is surely negative. But if person has shown a clinical radiological improvement in terms that the symptoms are gone, in terms your X-ray has started clearing up, then I don't think so a month is required. But any patient who's being considered for aggressive physiotherapy sessions, at least a sputum AFB culture, a follow-up sputum AFB culture should be negative before we can forego all the infection control measures. So sputum AFB smear is not the benchmark of considering a patient non-infective. We have to take that as a take-home message today. Okay. So sputum AFB smear can become negative as short as 2 weeks also. So for all practical purposes, like traveling on airplane, UK guidelines says 2 weeks of effective chemotherapy has been taken, and the person is fit to travel on airplane after a clinical assessment. But again, I will just tell you, it's a very individualized thing. Do not take it in general. There are no guidelines when we can initiate physiotherapies as such.
So is gene expert considered a better indicator than AFP?
Gene expert, yeah. So again, that's a very good question. Gene expert, once positive, can remain positive for 2 years. Okay. So we do not do gene expert for a follow-up testing ever. There is no point because it's just detecting, like we saw in COVID pandemic, that patients' RT-PCRs kept on coming positive for weeks after they were cured or they were symptom-free. So that is the basic principle here also. Gene expert is a type of PCR. It's a nucleic acid amplification test, which detects the molecules or the genetic code, the DNA of the TB. Now, there is a dead bacillus in the throat of the patient or in the lungs, which can keep on being shed for weeks to months or up to 2 years as well. So gene expert, if I'm repeating only on the clinical suspicion that I want to prove that previously my patient was drug susceptible. Now patient is failing or seems to be failing, and I want to see whether he has become rifampicin resistant or not. Otherwise, I will not repeat gene expert under any circumstances. Once negative, again positive, has no value. So gene expert, at the end of the day, before starting any new program, if 2 years have not elapsed, in a country like India, does not have any meaning. And it's an expensive test. It's 20 to 100 rupees in private. So we have to think what we should test. Instead of doing a gene expert, we should see if the patient has any symptoms or not, X-ray has cleared up or not, and we should ask the patient to give us sputum AFB culture. When I'm talking about AFB culture, I'm meaning liquid culture, TB MJIT culture. Sure.
Thank you, sir. So, any practical tips for students as many land up with TB, especially in government hospitals?
Unfortunately, that's the sad reality of residency in India. So eat on time, sleep on time, eat adequately. Do not diet during your residency. No matter if you're going to get married or you want to become more positive about your image, under no circumstances you should starve yourself. Okay. and vada pav is not a lunch or a dinner. Have proper dinner, have proper sleep, 6 to 7 hours. Okay, resiliency given that you may not be able to sleep on time, but at least target to have 6 to 7 hours of sleep. When you're getting free time, rest, study, and don't do Netflix and chill type things. So a lot of people play games and binge watch and or just simply scroll down the reels. Sleeping is the most untalked about feature of TB prevention. Okay, your body needs to have proper rest. And if your hospital is not providing you mask, luckily COVID pandemic has drastically dropped down the mask cost. You can get a surgical mask for as low as 8 rupees and a good quality N95 mask for as low as 30 rupees. So make sure that surgical mask is not being used beyond 8 hours. And if you're using a surgical mask or you're forced to use surgical mask, at least wear double mask. 3-ply mask I'm talking about, not 2-ply or 1-ply mask. 3-ply mask, you take double of it. That's not the recommendation. The recommendation to prevent yourself from an TB infection is wearing an N95 mask. In a setup like government hospital, we have to make sure or we have to consider each and every patient as a TB suspect. Okay? Do not let your guard down until and unless it's proven that the patient is not having TB infection.
Thank you, sir. There's one more question. Any specific physiotherapy intervention or related precautions which mandates while treating an active TB patient? So anything is contraindicated in active TB patients, or like we can give chest percussions, vibrations, all kind of.
So chest percussions, I would ask assess your patient and consider it. Only do it when it's helpful. Patient is having impacted mucus or is at a risk of impending collapse. Then only the chest percussion therapy should be instituted. Otherwise, most of our TB patients do not require, they require breathing exercises, they require muscle exercises rather than chest percussion. So yes, if there is a patient who's severely debilitated on bed, yes, in that case, chest percussion therapy is required. Otherwise, I dissuade my colleagues from doing physiotherapy until unless I need it for respiratory sample testing. That is, patient is not able to produce sputum, and in that case, and I need it for diagnosis, and that is the only other indication where I'll ask my physiotherapist to do a chest percussion. All my patients who are on ventilator and have tuberculosis, I make sure that that person has a SteadiCath installed to the endotracheal tube to make the circuit completely infection controlled thing. A lot of places, physiotherapists do open suctioning of endotracheal tube, so that should be avoided. In case if there is a suspicion, ask the patients to buy the SteadiCath. It's not that expensive anymore. It's under 1,000 rupees now in government setup if you need to buy it. Or in private setup, make sure that before any patient suspected or proven to be tuberculosis and who has been intubated, that's a rare thing which is happening now. But if that is the case, ask your critical care physician to install a SteadiCath. That is, I cannot underline the importance of it. Okay, enough to use that. That is the single most important thing we need to do in an ICU for protection of your nurses, for protection of yourself, and the visitors everyone. Okay.
Thank you, sir. That was really enlightening. On behalf of SOCVPR, I extend a heartfelt gratitude to each and everyone present here. Our sincere thanks to Dr. Sarthak for spending his evening with us, enlightening us with the insights and his inspiring words. We are deeply grateful for your presence and contribution. And let us continue to work together tirelessly towards a world free from the burden of TB. Maria ma'am, if you would like to say something.
I just want to thank sir for giving a lot of practical tips and insights, because these are always the issue. Many times the patient is still undiagnosed and he's referred for breathing exercise for session itself. And that's where we need to take a call. So the insights that so you have given us through it, that what are the things that are screening, and basically we always send them back many times, and we do feel bad that we are sending the patient back, but then yes, we need the clearance that there is no active tuberculosis. And another issue that always comes to light is, at least in my setup also, that's what we see is many times they come at a very late stage where almost a lot of destruction has happened. So it's always a hand forward that we are extending to all the chest physicians, that do send the patients early before it is too late for them when we are doing, for PR, because don't take it as a last resort. And all the tips that you have given, I'm sure each one of them, it's been so simple that each one of them can put it into their practice of how to screen, what to do, and how to go about it. I'm very grateful to you and Dr. Dholakia for suggesting your name. And I'm sure this journey is like a never-ending journey, and whatever from our side, and a lot of them have gained insight, so it will percolate further and go further. So thank you so much. Thank you very much.
Thanks a lot for having me.
Yeah, thank you. Same here.
Thank you, sir. Thank you, ma'am. Yes. And thank you, everyone. We'll end the meeting now.
We'll just take a group
Take a
pic.
group
Everyone,
picture.
yeah,
Yes.
everyone just put their cameras on.
Please put your cameras on. And everyone, please look at your camera and smile. Thank you. Thank you, everyone.